In this section, which is the third section of our lecture, we will discuss the management of stridor. In this section, for the management of the stridor, we will discuss the history-taking points for the stridor, what's the physical management of the patient with the stridor, and also the test done, which is the flexible fiber optic laryngoscopy for the diagnosis of the stridor. So the management of the stridor, the first and most important step is in any patient is when the patient comes to the office or in the ward, and the doctor, the first step in the management is the history taking. And this proper history taking is very, very important for the provisional diagnosis of the patient. So to reach the provisional diagnosis, proper history is important, and this is the art. History taking, good history taking is the art. All the doctors usually, they don't have this ability or capability to take good history. So in the history of the patient with the stridor, it's important that we should ask the patient about the time of onset of the stridor. What was the time, what was the patient doing at the time of the onset of the stridor? If the patient is sleeping, walking, running, sitting, so time of onset of the stridor is very, very important. Mode of onset, stridor is again very important. Mode of onset is important. We already discussed about the inspiratory stridor, expiratory stridor. So mode, what was the mode of the onset of the stridor, whether it was during the inhalation, exhalation, or biphasic stridor. Duration, how long was the duration of the stridor, whether it is relieved after a while, or if it is relieved, what are the factors that can lead to the what are the factors that leads to the overcome that the stridor is relieved. So factors in relieving the stridor is important. Duration of the stridor is important. How long was it? Then also important is the relationship of the stridor to feeding, especially in the newborn babies. This is very important that we should ask the mother that the stridor is related to feeding or if it's not related to feeding. Cyanotic spells, if the patient have cyanosis associated with stridor, cyanosis is the bluish discoloration of the skin that occurs as a result of asphyxia, poor supply of oxygen. So that means the stridor is associated with obstruction, airway obstruction. So cyanotic spells along with stridor is important. Then aspiration or ingestion of foreign body, again very important. If it's in the children, usually when the children, they are playing with the toys, small toys, blocks, they put them in the mouth and they ingest them. That can cause stridor or airway obstruction. So that's very, very important, especially if the mother is not paying attention and children are playing on their own and they have sudden spell of cyanosis and stridor. The first thing that should be in your mind is the foreign body obstruction. Then laryngeal trauma can also be the cause of the stridor. So all these are important points you can ask when you take the history, and that can lead to the provisional diagnosis of the patient. Then physical examination. These are the three divisions. We have the supraglottic region, then the glottic region, and subglottic region. And each region is separately associated with the whether it's the inspiratory stridor, biphasic or expiratory stridor. And inspiratory stridor is usually associated with any problem in the pharynx, throat, or the supraglottis. And then the biphasic type of stridor is in the glottis and cervical trachea, and then the expiratory stridor is in the thoracic trachea and bronchi. So that is the three divisions which gives us the idea if it's a patient has inspiratory stridor, the first thing that comes to the mind, okay, this might be a problem with the supraglottic region or the pharynx. When they have biphasic, it may be like it's a glottis and cervical trachea, and if it's expiratory, then it's the thoracic trachea and bronchi. So very clear demarcation of the type of stridor that is present. Associated physical examination associated with respiratory distress. Usually on physical examination, the very important sign that is associated with respiratory distress, and that gives the idea to the physician that this might have some obstruction, underlying respiratory obstruction, when there is recession. Recession of these, this is the region that's the suprasternal. Sternum is the breastbone, and this is the suprasternal region or the intercostal region. Intercostal is between the ribs. Ribs play and the intercostal muscles which are present in the between the ribs play a very important role in the respiration. So whenever there is breathing obstruction and there is breathing dyspnea, usually there is intercostal muscle recession present. So that is suprasternal notch, sternum, intercostal spaces, and epigastrum. There is recession present on physical examination. Any type of stridor indicate obstruction site. So as I already discussed, obstruction site is we can find the obstruction site by the type of stridor that is present. Then associated fever, if on examination, on general physical examination known as GPE, general physical examination, if there is intercostal recession, suprasternal recession, that gives the idea that there might be airway obstruction or stridor present due to some causes. If there is fever along with on the general physical examination, then that's the cause mainly is due to some infection like epiglottitis, pharyngitis, laryngitis. All these different infections can lead to the presence of fever, and they is associated with fever. Stridor disappears if there is laryngomalacia, micrognathia, macroglossia, innominate artery compression. So laryngomalacia, we already talked about it. There is flaccidity of the larynx, and there is when it is we can breathe, there is bulging or inbulging of the larynx. Micrognathia, small, there is a jaw that also can cause a stridor because of the obstruction. Macroglossia, enlarged tongue, it can block the airway and there is respiratory obstruction. And innominate artery compression can also lead to stridor that can be disappear. Sequential auscultation with unaided ear. So stridor is loud, noisy sound. We don't need the help of the aid or stethoscope for hearing the stridor. So it can be heard with the unaided ear. Examination of nose, tongue, jaw, pharynx, larynx, that can give us the idea about all these conditions, whether there is laryngomalacia, micrognathia associated with jaw, macroglossia with the tongue. So the examination should be make sure in the patient with the stridor, examination should be complete. We should look for all these structures and we should look for any lesion or abnormality that can be associated with obstruction and stridor. Some associated characteristics of stridor are very important. Patients who have stridor, they have a history or associated character of snoring and snorting sounds. So they snore at night when they sleep. They have loud snoring sounds, and this snoring is as a result of stridor and due to difficulty in breathing. Nasal or nasopharyngeal cause. Gurgling sound and muffled voice is due to pharyngeal cause. Hoarse cry or voice is due to laryngeal cause at vocal cords, normal cry. And then we have expiratory wheeze is due to bronchial obstruction. So all these are the characteristics that are associated with the stridor. It might be present in the patient who have stridor. Wheezing is very common. Expiratory wheeze is also common in patients who have asthma as a result of narrowing of the airway, and then when the air passes through that narrowed airway, they have that wheezing is present. So these are all the associated characteristics with the stridor. Flexible fiber optic laryngoscopy is, as you see, this is the laryngoscope, examination of the larynx through the nose. So on the way, the nostrils are examined, nasal cavity is examined, nasopharynx is examined, then larynx is examined. And the good thing is it can be performed as an outpatient procedure, and in the office, we just need the local anesthesia, topical anesthesia for this procedure, not the general anesthesia. It's an outdoor procedure. Examination of nose, nasopharynx, and larynx is done, and is used for the diagnosis of laryngomalacia, vocal cord paralysis, laryngeal papillomas, laryngeal cyst, congenital anomalies, and laryngeal clefts or web. All these are congenital conditions. We talked about them in the first section that they can cause airway obstruction and as a result can cause stridor. So they can be diagnosed by the fiber optic laryngoscopy. So that was all about our section 3. Thank you for watching sqadia.com.